Bismillahirrahmanirrahim. Today's our question is that 23-year-old man is transferred to the emergency department following a demolition site accident in which a beam fell on him and pinned him by the chest. He has a clear airway and is able to speak to you in gasps. His blood pressure is 110/75 and pulse rate is 105 per minute. Air entry is diminished over the right side of the chest, with a small area of subcutaneous emphysema palpable posteriorly. CT scan shows he has a bilateral rib fracture from the right second through to the seventh rib, with a small hemopneumothorax on the right as illustrated here. After the scan, his breathing becomes more labored and he shows signs of paradoxical respiration of chest wall retraction during inspiration. Which one of the following is most appropriate initial action to take in his management? Option A is strap the chest. B, which is insert a right-sided pleural underwater seal drain. Aspirate the right pneumothorax. Institute a positive pressure ventilation via an endotracheal tube. Administer bilateral intercostal blocks for analgesia. The paradoxical respiration, chest wall retraction with inspiration, can occur when a flail chest wall segment is present. Respiratory embarrassment follows with an impairment of gas exchange proportional to the size of the ineffective flail segment. The patient's condition requires stabilization by establishing positive pressure ventilation assistance administered through an endotracheal airway. So, correct option is the D, positive pressure ventilation assistance administered through an endotracheal airway. The chest strapping is ineffective with a large flail segment, as in is the case in this instance with six rib fracture. Aspirating the small pneumothorax will not be immediately effective as labored breathing is due. Aspirating the small pneumothorax will not be immediately effective as labored breathing is due to ineffective ventilation from paradoxical flail chest. Once a positive pressure ventilation has been instituted, his physical signs and effectiveness of gas exchange and oxygen saturation must be carefully monitored, as there is risk from a positive pressure ventilation of exacerbating the small right pneumothorax currently present, especially if positive and expiratory pressure ventilation is used. Precautionary insertion of right-sided pleural underwater seal drain tube would be appropriate as an early subsequent step, but the immediate management is to ensure that the endotracheal intubation and ventilation have been secured. At a large stage, intercostal nerve anesthetic blockage may also be helpful, but again, this would not be the most important initial management. So D is correct, which is institute a positive pressure ventilation via endotracheal tube. A mother brings her 2 year son to the clinic. She is concerned that her child has stopped growing. The child is on the 50th percentile for height and weight, and her previous record shows he has remained on this growth curve for height and weight. You notice that his height has not changed from 3 months ago. Which one of the following is the most appropriate next step in the management? Reassure the mother and review in 3 months. Order a growth hormone studies. Order bone films of the hand and wrist. Order a thyroid studies. Advise the mother to increase the child's calories intake. So this child is on the 50th percentile for height and weight, and previous record shows that he has remained on this growth curve for height and weight. And since 3 months, his height has not changed. Each child has a different rate of maturation. Thus, if child's growth curve declines, one might obtain a glimpse of the hands and wrists to rule out the short stature or constitutional growth delay. In this case, the child has remained on the growth curve. Thus, we will probably show an increase in height within the next 3 months. The child up until 3 months ago has been on the 50th percentile. Linear growth in infants has been shown to occur in incremental bursts rather than continuously. Although thyroid pathology, growth hormone deficiency, and diet are important in growth and development, neither taking a detailed dietary history nor increasing the calories intake would be appropriate in this case. So reassurance is the most appropriate advice. Option A is correct, which is reassurance. It is essential to plot the growth of any child as a mandatory assessment of appropriate physical progress of the child. Estimation of a cursory visual surveillance without actual measurement is a fraud and with hazard. The pattern of growth of head circumference, length, and weight are all relevant and are best plotted on growth charts that are widely available and determined for Australian children. For young infants, reference to the Infant Welfare Record Book containing progressive measurement over time is an excellent method of assessing growth. Progressive deviation from the expected percentile lines, either up or down, may indicate the need for further investigation. For example, head circumference measurement climbing from 15th percentile to 98th percentile over an 8-week period would suggest a progressive hydrocephalus. We are the product of our genes, and very often a careful survey of family members measuring their height and weight can reassure us that the growth of a small child is appropriate within his family. Similarly, a series of head circumference measurements running on the 98th percentile in a child of a normal development are consistent when one or other parent has a similar head circumference measurement. So here we will do the reassurance. So reassure the mother and review in 3 months.